here, but seizures today. Everybody rested?
No.
Okay, we started out with so few. I was afraid if not everybody's going to be here today. We got to have graduation services come in at 3:30. Let's get started. So got a little bit shorter presentation for you to fill that time. So make sure you stick around for that piece. We'll take care of your degree check forms and a few other things when they come in. So that will come later. Other than that, we'll get started. Everybody's so far feeling all right. We've got diabetes content. We've just done liver and pancreas, and now we're on to neuro with seizures. So just when you thought you had the last topic, here we go with some more. This one's gonna have some meds in it too. So I know diabetes has quite a bit. Has everybody seen the study guide in there in Moodle?
Yeah.
Yes, it's in there. Should we? Okay. So I got a little bit of a study guide. Of course, not everything's in there, but just taking PowerPoint, which is a condensed version of what's in your books, and then the study guide, which is a condensed version of that. So just some place to start, some place to kind of get your brain wrapped around the super important pieces, and then kind of filter in all the details later once you're confident with what you've got in front of you. Okay, so just something to help you out, kind of get things organized in your brain, right? So seizures now. So I've got a little outline here. This is how we're going to go with this presentation. I'm going to start with pathophysiology like I usually do, just kind of make sure you're understanding how that impulses are sent across nerves. That's going to be super important when we get to medications. Like a lot of other topics, it's really good to start here, especially with your studying, because if you really understand what's happening, it's going to make sense. More so in this topic with your medications than really signs and symptoms, but it'll make sense there too. Of course, etiology and some causes, and then there's different stages of a seizure. We'll talk about that. I struggled a little bit with the order of the way we go through things because we could talk about all the different types, but some of the types have to do with the stages that you're doing. So it's like, which came first here? Let's talk about stages first, and then we'll get into the different types. We've got generalized and focal. What's the difference, and what falls in between underneath that? So have any of you worked with seizures in the past? Like, have you taken care of patients with seizures? I see some head nods. I know some ER back there. Definitely has probably seen a few come in and had some. Yeah, same. Yes. Neuro units. Anybody working on a neuro unit? Anybody see a seizure that didn't happen on a neuro unit? Potentially questionable seizure, not sure, right? Potential seizure activity. So it doesn't have to be on a neuro unit to be a seizure. Anybody can have one anytime, anywhere. Hopefully not right now while I'm up here with my headache. So complications of the seizures, what are we worried about? What could happen? What could go wrong? When is it an emergency, right? And then some diagnostics. How do we diagnose seizure disorders versus other causes? And treatment. So medications, obviously, that's what's kind of a big topic in there. Not as big as diabetes, though. I think that's your biggest one when it comes to medications and pharmacology. So what surgical treatments are available, a little bit about nutrition, and some nursing interventions thrown there on the end. So that'll wrap it up. Okay, so with patho, we're talking about nerves. You remember the nerve cell kind of has like the dendrons at the end, you have the axon. And then what we're really wanting to talk about when it comes to sending in that nerve impulse from one nerve cell to the next happens in between. So they kind of lay alongside each other, and there's a gap in between, that synaptic gap. So when the signal's sent down the nerve cell, that's where that transfer of information happens. So you remember, I could draw it out here, but outside of the cell, it's typically a negative charge. You get sodium outside the cell, and then it comes in to the cell as the impulse is moving down the axon to the axon terminal. What's happening there is now we've opened up some calcium channels at the end here, the axon terminal, that's changing that charge and causing these neurotransmitters to then transfer. Where the new cell receives that message from the neurotransmitter and either continues with that impulse down in the new cell or it inhibits it, depending on which channels are open. So that's basically what's happening. So the next slide is gonna show you a little bit about that. So we have two different types of neurotransmitters. Those are the chemicals that are at the end, that axon terminal, at the end of those nerve cells. So we either have excitatory or we have inhibitory neurotransmitters. So that's the chemical that sends the message to tell the next nerve whether it's gonna activate or deactivate. Okay, so far you with me? Okay, so let's back up. So right in here, my pointer's gonna show. These are where your neurotransmitters sit at the end. The axon terminal is the end of that long nerve cell, right? So you've got this electrical impulse coming down the nerve and it hits this section here, and it's all sodium channels all along the length of the nerve cell. But once you get to this axon terminal, now it's sending in calcium and it's changing that chart, that pause to a chart, changing the polarization of the end of the cell from negative to positive, letting that calcium ion come in, which then pushes those neurotransmitters to the edge. So those membranes fuse and it releases all these neurotransmitters. That is the message, that is the chemical that is telling this next cell whether these channels are gonna open and let that conduction continue through, or whether we're going to send ions outside of the cell. So if it's gonna open and allow it through, then we continue on with an impulse. If a different channel opens up with a different type of neurotransmitter, it's gonna slow down the action of that nerve cell so the electricity doesn't continue on. That's where this slide is gonna explain that a little bit more. So if we are sending a nerve impulse or electrical impulse down a nerve and we wanna carry a message through to cause excitation of that nerve cell, we're activating the glutamate neurotransmitter. Glutamate is the neurotransmitter that sends an active signal, whether it tells a muscle cell to move or whether it tells like a cell to release a hormone. It's the message that tells that particular cell to then have an action, right? So muscle moves or whatever that cell is programmed to do, that message through the neuron is gonna go and then activate and excite that cell when glutamate is released, okay? So it's gonna bind to these NMDA receptors. So these are your receptors, these little blue things right here. It's gonna receive that neurotransmitter. And when it's glutamate, it's gonna tell that particular receptor to open, and that charge changes, allowing electricity to continue down the cell. So if this is glutamate, it's telling that nerve impulse to continue down, right? On the flip side of that, inhibitory is inhibiting that electrical impulse. So GABA is the neurotransmitter which binds to GABA receptors. They made that one nice and easy for you, right? Then we're changing the charge. Chloride, so it's a different type of receptor that opens up, and chloride is gonna enter the neuron. And so you're having an opposite effect when it comes to charge, positive and negative charge, which slows down and deactivates that impulse on that nerve, telling that cell to slow down and cease the activity. So then the nerve impulse will stop sending, or the muscle will stop contracting once that neurotransmitter tells it to. So, you got that? Glutamate excites the cell, and then we have GABA that inhibits the nerve cell. And this comes into play when we talk about medications. We're gonna have some medications that are gonna increase this GABA neurotransmitter to tell that overexcitation of that nerve cell to slow down and stop firing or misfiring, okay? Right? It makes sense when we're talking about CNS depressants and those kind of medications that are gonna slow down that electrical conduction by acting upon these neurotransmitters, either slowing down glutamate or increasing GABA. All right, and that'll make more sense when I talk about what is a seizure and what's happening. So are we good on the neurotransmitters? That is the hormone at the end of the axon that is released when that nerve impulse comes down, and tells the nerve to either excite or slow down, depending on which neurotransmitter is being emitted, okay? That's basically what you need to know there. So neurotransmitters are the chemical that's sending the message to either excite or inhibit that nerve cell. And either continue with excitation or continuing with the electrical impulse or slowing down that electrical impulse. Because what's a seizure? What's happening with a seizure? So it's kind of up there in front of you, but what's happening? What's really happening? Yes, misfiring in neurons, right? So you've got nerve cells with lots of electrical activity happening, and it just keeps going over and over again without any slowing down, right? We're overexciting the electrical discharge. Neurons in the brain, and that's going to interrupt normal functioning, right? So too much stimulant, perhaps. Too much neurotransmitter, not enough of the inhibitory transmitters. Sometimes it's just happening because of damage to some of the cells, or maybe lack of those neurotransmitters. Seizures are sometimes caused by other things. It's a provoked seizure, not necessarily a seizure disorder, but like certain things like medications or a fever. And we'll talk about some of those examples in a bit here, but seizures can be provoked by something else. So it's secondary to some other problem that's happening, okay? Unprovoked is the other piece, where there's no systemic or metabolic reason, the seizure just happens, okay? You don't really understand necessarily in some cases. Other cases, they're unprovoked. It's sort of in a secondary way because of permanent damage that's been done, but then when the seizure happens is what is unprovoked at that point. We're gonna talk about that some more. So seizures can come along with any other, like a variety of different disorders, right? Like I said, we've already talked about they can happen for no reason, no cause. That would be your unprovoked. And I mentioned earlier it can happen at any age. So even in pediatrics, I've probably seen more kids with seizures than I have with adults in working in peds. I had like 5 years of adults, and most of my career has been peds, but a lot of our chronically or medically fragile children, we call them, have this accompanying seizure disorder, aka epilepsy, along with whatever else is going on. Okay, I'm gonna pause here. Everybody good? So something's wrong with the nerve cell. It's causing a misfire. Could be something wrong with the neurotransmitters, with that messaging, that something's not allowing that message to slow down and balance that homeostasis piece. So we've got too much excitatory neurotransmitters, not enough inhibitory neurotransmitters, and we've got this misfiring going on due to some kind of damage or some other unknown cause. Okay? Ready to move? Yes. Okay. So I've already mentioned a little bit about provoked and unprovoked. So this is going to explain it a little bit more. So provoked, really this is something like if you fix the underlying problem, the seizures go away, right? That would be a provoked seizure, meaning there's something wrong, I can fix it, and that then fixes the seizures. Isn't that how we want to do everything in medicine? Fix the underlying cause, and then this symptom goes away, right? So this is usually a systemic or a metabolic cause. We talk about metabolic causes, metabolic things a lot lately, right? Especially in this class. Endocrine and metabolic. So fever, have you ever heard of febrile seizures? Usually in infants, a fever can trigger a provoked seizure, can provoke a seizure. CNS infection, what's a CNS infection? What's a CNS, central nervous system infection? Infection in the brain, AKA meningitis. So in the acute stage, so kind of mention cerebral infections on the unprovoked side, so don't want to confuse you there. An acute CNS infection can cause a provoked seizure. Hypoglycemia, that keeps popping up too. Thought we moved on from diabetes. So hypoglycemia, bolded, underlined it. You guys know me. Because this is gonna overlap a little bit with what we talked about. So remember, okay, bringing back the other lecture. Hypoglycemia is really bad in diabetes, right? Our brains want sugar. We need it to function. When sugar's free floating in your body, your brain and your liver use it first. Then the rest of your body's gonna use it, and then whatever's left over gets stored, right? But if you're not processing that sugar, you can't use it, you don't have insulin to allow it to use, you can then have, or you have too much insulin, you drop your blood sugar, or your blood sugar goes up high, but you then have too much insulin, now you don't have enough free-floating sugar, you're not eating, right? And all of that's taken care of, there's nothing left. Your brain says, I need some, come on. Hypoglycemia can trigger a seizure, okay? If it goes too low, dangerously low. The patient becomes unconscious, and then they can go into a provoked hypoglycemic seizure. Electrolyte imbalances. Do you remember in pt1, we talked about two major electrolytes? What were the two we talked about? Sodium and potassium. What did we say? Those are like urgent ones. They're all important, right? Calcium is involved here too. But what did we say about potassium? Heart. What did we say about sodium? Neuro, Na for neuro, right? So hyponatremia, not enough sodium, that impulse is affected because sodium is moving in and out of that nerve cell and can cause problems there with seizures. Same with potassium, calcium, chloride, all of those things too, but primarily sodium because it is what is in and out of that gate as that electrical impulse moves down that axon. Hypoxia. What else does the brain need besides sugar? Oxygen. If we don't have enough, our brain's gonna misfire. Not all the time, it's just these are potential causes, right? Cerebral edema. What's that? Swelling on the brain, fluid around the brain. So it can be damaging some neurons, right? And damage to neurons can cause misfiring. So you can logically think through some of these, right? Damage is what's happening usually in these cases, or it's causing a problem with that electrical impulse. Alcohol or barbiturate withdrawal. What happens with alcohol withdrawal? You know? Seizures. Part of DTs, right? Technically. Alcohol also can cause that hypoglycemia, so on the other side of that, too much alcohol can cause a seizure too. But the withdrawal in particular is what we're talking about here. And barbiturates also. Barbiturates, so if you've had a patient or you've heard about people on seizure medications, I'm jumping the gun a little bit here. We want to come off them slowly, because if we come off them immediately, we can throw them right into a seizure. And we give the medication for seizures, so no wonder you guys are confused, right? But we don't want to come off of them too quickly, because then we can put them into this withdrawal, and they can have problems and have more seizures. Same thing, certain medications, right, have a side effect, and some of them are given for seizures. But certain medications, depending on the dosing, they don't get enough dosing, that can trigger more seizures if it's not in the therapeutic threshold. Okay. Again, provoked. If we fix the underlying cause, the seizures go away. That's the main point for this one. Unprovoked, there really is no reason or cause, like they can't determine what might have set off the seizure, but we do know in some of these cases, these chronic neurologic conditions, we have damage to these cells. So again, that you could say a stroke can cause a seizure, but it's an unprovoked seizure, meaning it wasn't like a specific moment like you have like hypoglycemia that you can correct and fix it. It's just permanent damage to those cells, and then those seizures just come without warning at any particular time, just whenever they feel like it. So stroke, cerebrovascular accident, CVA, brain tumors, because of the damage that can be done there. So severe cerebral infection. So we had CNS infection on the acute side initially, and then later on you can have damage if the infection was bad enough, right? And that's, near impossible to repair. You get permanent brain damage sometimes in real severe cases. Traumatic brain injury, right, trauma. Hypoxic birth injury. You guys probably talked a little bit about that in OB class. Who knew that was gonna keep coming up again too, right? That class. So, like a difficult birth, long time in the birth canal, baby didn't get enough oxygen in that process, decelerations, heart rate, not enough perfusion to the brain, they can have a hypoxic birth injury. What do we call that, do you know? Typically, or, let's see. Like, say again? No, she's thinking out loud. So, an anoxic brain injury or hypoxic brain injury in an infant, cerebral palsy, we often will hear it term that. That's essentially what happened with cerebral palsy, right? So CP, they didn't get enough oxygen and now there's this permanent brain injury. And they very often, they have what we call epilepsy, unprovoked seizures, right? Because of that permanent brain damage that was done. So cerebral palsy doesn't get worse, right? It is what it is. So they're where they're at. They get therapies to help them work with within their limitations, but it's not something that gets worse. Because the injury is done unless there's more anoxic brain injury that for whatever reason happens. But they're at the state that they were born. As much damage that happened during birth is what stays. So that is cerebral palsy. And then neurodevelopmental disorders, so your autism spectrum disorders, they don't really understand the correlation here, but they know this is neurologic, and a lot of times seizures accompany. And it's not always it's not how it's diagnosed too. Seizures can come later in somebody with autism spectrum, so they might, develop differently, and they see like some of those repetitive like tics that sometimes they have, and not necessarily seizures. Full-blown seizures will sometimes come and develop later, and they don't know who's going to have them, or not every kid with autism is going to have seizures, but it does seem to be something that happens often. Okay, so got provoked and unprovoked, right? What's important to know about a provoked seizure? Say again? Yeah, that too. But what about it? Provoked means there's a cause, and if we fix the cause, right, we underline cause, then the seizure will go away. Unprovoked is what your epilepsy is, or a seizure disorder, right? So it's not epilepsy if it's caused by hypoglycemia, right? There is a little bit of a genetic link, so we're talking about causes still here, even though genes don't really cause it, but they've found there's several genes, I think there's like 400 different genes that could be associated with seizures too. And it really, the point here is to say that it can predispose somebody with, if the environment is set up right, or the emotional piece too, because there is a psychological component that sometimes goes with seizures. And we'll briefly talk about that too. But 70% of those with a seizure disorder have some genetic abnormality, and they're still studying these things to see if they can pinpoint and tell based on this genetic abnormality what type of seizures you're going to have, if they're going to have seizures, et cetera, et cetera. They're also seeing that some of these mutations just change their seizure threshold. So if the environment is set up right, then they might have a seizure. And sometimes these people may have a seizure, an unprovoked seizure, just one single event, and then never have one again. And it could have just been this genetic component and some kind of environmental setup that just, the situation, the perfect storm didn't happen again, right? Oh, and just Down syndrome is on here because that is a chromosomal disorder, and that often does have seizures like that. Okay, so on to the stages. So who's witnessed a seizure before? Okay. So you may have seen all 4 of these stages, maybe 1 or 2. They don't all happen to everybody. But there are 4 possible stages, and certain seizures don't include like an aura stage, right? So we'll talk about that too. But what are the stages? We've got prodromal, so this is the early stage, right? The symptoms that and if you've got a seizure disorder, aka epilepsy, some people will recognize this. Like they've had it over and over again, they start to see a pattern, they know how they feel, and they remember the last time they felt this way, it turned into a seizure. So sometimes it can be hours before, or even days before, they start to not feel good, and they have their own specific symptoms, and for some patients, like, it can change. Like sometimes they have symptoms before a certain type of seizure, and then another day there's a different set of symptoms that goes with a different type of seizure. Some of those could be like they're feeling mood changes, depression, anxiety. Some people feel euphoric, some people feel fear, just for no reason. Anger, agitation, insomnia. You can't really tell that's bolded just because that's a big one. It's just more common. And they notice, like, I just can't sleep. So it's some of that, they're not really 100% sure if that's provoking, kind of in a sense, a seizure. If you're sleep deprived, it can put you more at risk for, but it's also, they put it in this prodromal category because it can be a sign of an impending seizure coming. So that excitability is happening, it hasn't quite triggered a seizure, but it's starting and it's keeping you awake to the point where they can't sleep. So impaired focus and attention. I've worked with like some teenagers. There's one that, he's probably gonna be my story that comes up. A friend of mine's son, and also somebody who was at the middle school when I was the school nurse there. So we have a good relationship with any of our kids who have seizure disorders, that we know what their seizure type is and what their rescue plan is. And a lot of times he would come in and come find me, or he saw me in the hallway when he's on his way, and he's like, I feel one coming on, I'm coming to you, I'm coming. So they ahead of time will come to me to have safety in the event that one is coming. So it's kind of nice that they get this prodromal stage, or even the aura that comes next, because it's like a warning for them, right? Next slide is actually the warning, because this could be really long. And it's not always recognized, especially if there's like a change in their seizure pattern, and they didn't realize this agitation and anger. Nursing school got in the way, right? I was frustrated with nursing school, or depressed, or tired, and didn't realize, oh, this was an impending seizure, because my life had a lot going on at that time too. Again, chicken or the egg here, right? Is that provoking a seizure, or is this really the prodromal, just the lead up to a seizure, right? Sometimes GI, urinary issues can happen, like GI upset, diarrhea, those kind of things. Okay, the next stage is the aura. So this is seconds or minutes prior. This is the, oh, it's coming, right? And this is one that my friend Jonathan would have. He would get an aura, not always. Sometimes he would like see something out of the, like his vision was kind of changing, kind of like a tunnel vision, not quite to passing out, but he had his own unique story. And I've got some videos. You'll get to see some videos of people describing their experience. But again, not for every seizure. This goes with one particular type of seizure, and since we haven't talked about them yet, I'll tell you when we get there. But it can be a warning sign, and our job as the nurse is to help the patient prepare. So if they're telling you, I got one coming, they know, and you believe them, and we go ahead and we prepare for it, make sure that they're safe, right? So there can be vision or hearing changes, any of the senses really, a strange taste, a smell, which kind of goes with the hallucinations, things that aren't there, things that don't make sense. And they're alert and aware of what's going on. It's not like there's an unconsciousness. The only reason we know about an aura is because patients are able to describe what they're seeing and hearing and feeling, in the aftermath, or even while it's happening. They can say, oh, I know it's not there, but I see this flashing light. They can sometimes have like a dizzy feeling, and it could be just because the confusion and that visual change that's there, that they know that there's something there, but it's kind of making them a little disoriented and resulting in a little dizzy feeling. Okay? So then we have the ictal stage. So we've had the lead up, this is the event. So, and I have a big stopwatch on here, because when we get to this point, this is where our job as the nurses, we're timing. And we know when's coming. All right, here it is. I don't have a second hand, but we're looking at the clock from the seconds, right? Because some seizures only last a few seconds. We want to know how long that seizure lasted. So we need to know the start of symptoms and when the ictal stage stops. So most seizures on average about 1 to 3 minutes, can feel really long. I got a whole other slide on status epilepticus, but I put it in here too because it's really important. The reason we're timing is to make sure we're not going into what we call status or status epilepticus. All right, that's when it's beyond 5 minutes. So you're all aware of this? Seizure happens, we're clocking it. If it goes beyond 5 minutes, that's when we're starting our seizure protocol. Certain patients may have their own specific protocol that's ordered for them. They have certain rescue meds that they use. That's considered an emergency. So again, we'll talk about that later. But during the ictal stage, the symptoms can vary depending on the type of seizure. And that's going to depend on where the lesion or the damage is in their brain. So, partial or full loss of consciousness can occur, or no loss of they have complete awareness, again, depending on the type. And there can be motor involvement or non-motor type seizures. Okay. Confusion, memory loss, this kind of comes later, but again, if they're in a non-aware state, they're not going to remember the event, so there's going to be some kind of memory loss. There could be other memory loss too, depending on where this damage is and where the trigger is in their brain. It may have, like, they might forget something from their past, but what that really means is that they're not remembering the event specifically, so memory loss of the event. There can be speech changes. So there's certain types of seizures that you might observe, and when you throw speech changes in there, what are you thinking? Think neuro, stroke, right? So some of them can look like other things. It can be really hard to figure out what's going on with somebody. So if you know their history, it might help you, but speech changes can occur because it depends on where this is happening in their brain and what part of their brain is being affected. Depends on what type of symptoms you're gonna see. And then there's loss of control of body functions of some of these types. So bowel and bladder. So that's the event, and now this is the post-event, post-ictal, right? Post-ictal state. This is that recovery piece. So depending on the type of seizure, I mean, that's a lot. Misfiring is a lot of activity in your brain. Imagine you going in a sprint, and then you're done sprinting. Aren't you tired? You need to sit for a minute, right? Kind of exhausted. Their brain's exhausted. So this says 5 to 30 minutes on this slide, but some people can go days. They need a couple days recovery. Might be off from work if they're working. Some can't work because of this, so they're on disability. So recovering, the time again is going to vary, hours to days. Absence type seizures we'll talk about, but some seizures have immediate recovery, so there really is no postictal stage. It's super fast, and there's really no recovery. They're just in and out, and they're good to go and carry on. The most common is extreme fatigue. So, even somebody with a short, quick recovery, if they have several of those type of seizures over time, will probably be fatigued. So you're gonna expect fatigue, especially in the full body type seizures that most of us are familiar with, where all the jerking and muscle movements are happening. But even without that, the brain is misfiring, the brain's tired. Confusion, especially with certain types. Lack of coordination or speech, so it might take a little while for some of those processes to come back. So if that part of the brain was affected during the seizure, and even though the seizure has stopped, it takes a little while for everything to reboot. Just like you turn your computer off and you get the little spinny thing loading. The brain's just loading during this time. So sometimes it takes a few minutes for things to come back. Feelings of humiliation or guilt. When would that happen? Out in public, grandma, lost bowel and bladder. It's difficult, yeah. So usually these people have like a plan for how they handle being out. What was that? Driving. So we'll talk about that too. There's certain restrictions depending on what type of seizure people have. headache, and so it's some of the guilt, making other people drive for you. What we're talking about in post-ictal state. So again, there's a lot of these feelings that can go along with certain types of seizures. Some of the non-motor type seizures, so you have an emotional response at the end too, and no reason, like no reason, crying or upset, angry, so strange feelings that don't make sense to what was going on. Headache, that's another big one too. Fatigue and headache, I would say. And then injury, so if they fell, there's going to be an assessment piece post event, right? We're going to make sure that there weren't any injuries that occurred during the seizure. So we're going to be checking our patients out. Okay, so on to the types. So the different stages kind of help you to understand the process of a seizure, and that's going to help some of this make sense too. So the different types, we have a focal onset and a generalized onset. Those are your primary, right? And within focal, we're going to talk about aware and impaired awareness. You can kind of see what's going on there. With focal seizures, you can be aware of everything, or maybe not aware. And then on a generalized onset, we're typically talking about tonic-clonic and absence type seizures, which have a motor and a non-motor component too. And then there's an unknown onset. So it may be like any of the above, but they're not really sure where it's originating from. So how these are categorized, this focal and this generalized, depends on where the brain lesion is or where the damage is occurring from. So where is the onset of the seizure? So with focal, it's isolated to one part of the brain on one side of the brain. Left, right, front, back, just one little focused piece of their brain. And then, so they can be aware of the seizure, and they also may not be aware. Then you have generalized onset. So we've got origination from hemiplegia, or one part, or one lobe within one side of the brain. Generalized means what? All throughout. So all generalized onset seizures have an unawareness to them, impaired awareness. They are unconscious during the event. You can see we have motor and non-motor under each one. So that means we have motor movement involvement with all the different types. So we're interested in knowing where the origination of the misfiring is occurring and whether there's motor, non-motor, and awareness or unawareness. The only type of seizure where somebody is aware is what type? The focal. Okay. Focal awareness seizure. And then you have focal impaired awareness. Right, we're going to get into these a little bit more, but this is a good little overview of your different types and the big overarching umbrella I always talk about and the details that fall underneath. Okay. They did change the names. So if you've been in healthcare for a while, you heard of pt1 and grand mal and simple partial and complex partial. Anybody heard those terms? Throw them out. They're all changed, but it's been a few years now. So, it's important to kind of know, maybe not so much for test taking, but when you're out there working, you might still hear people use those terms, or even patients who've had seizures for years are still calling them what we used to call them. So you might be like, what do you mean simple, partial, or complex? What? So we'll talk about that too. All right, so let's discuss generalized first. This is typically what people imagine when they think of a seizure, the big tonic-clonic one. We're gonna just go right to the big one. That is what used to be called grand mal, so that's why I put that in parentheses there. It's the most common generalized type seizure. Just of those types, usually it's tonic-clonic. So this one lasts just a couple of minutes. Typically that 1 to 3, like your average seizure we talked about earlier, it's not very long. But it starts usually with that tonic stage, that tonic phase, and it's just that first 10 to 20 seconds we have this tonic tense, right? Everything tenses up. And during that phase, because everything's tensing, it's pushing on the diaphragm too, so you have that cry out, pushes all the air out. As the body stiffens, that can create salivation and foaming sometimes because of that air escaping with that saliva response, and just creates bubbles. So sometimes there's drooling and foaming. And because everything is so tense, it's a brief state of apnea too. So you might see a little cyanosis, especially if it's lasting a good 20 seconds, right? And then after that tonic state, they go into the clonic jerks, that rhythmic or that clonus, that clonic phase, 30 to 40 seconds or up until that 3-minute point. So tonic is initially, usually the quickest, and then they go through the jerking for a while until it eventually resolves. You can have tachycardia, hyperventilation, sweating. Remember, all the nerves are being excited. It's all throughout the brain, right? So it involves all areas. It's bilateral. They lose control of bowel and bladder typically. All right? So it's both together. It starts with the tonic and then they go into clonic. So there's an EEG, and this is just a video-assisted one. We do that pretty often. We'll talk about EEGs later, but they video so we can watch their symptoms. You see tonicity right now, the tonic, and that moaning. It's an older video too. And it's like this little microphone on the camera. That's a family member at the bedside. They press the call light and the nurses came. So they're usually on alert for that. Like, oh, they're having one, they rush in and help. You see it resolving. So did you see like that the instinct everybody wants to put their hands on when you see somebody jerking like that? We're not going to stop a seizure physically. It's going to occur. It's kind of one way we know that some are psychogenic versus not. In psychogenic ones, we can usually stop the seizure by holding somebody because it's not a true seizure. But this is clearly a true seizure, and that's just the instinct to protect them, to keep them from getting hurt. We're going to talk about seizure precautions too, and you can see that going on. You guys might have set that up before, especially on a unit. Maybe you're working as a tech and they're getting an admission and they want you to initiate seizure precautions, right? You had to get the room set up for that. Okay. So that is your tonic, clonic. That is typically what we see in the movies, what everybody kind of knows off of television and stuff like that. But there's so many different types. Okay, so within our generalized onsets, remember we're just going right to throughout the brain, right? Tonic clonic has both. Starts with the tonic, moves into clonic, but you can have an isolated tonic seizure or an isolated clonic. So just a tonic seizure that doesn't involve clinicity, or a clonic seizure. So clonic is a little more rare. They usually go into that tonic clonic state. They'll start with the tonicity. Or you can just have that stiffening type seizure and then it resolves. The medical daycare I used to work at, we had a little boy who would go into a tonic seizure and he'd get in the corticate position. He's facing inward and just kind of stiffen up, would take a few seconds and then you relax. So that, again, is a little bit more common in peds in that situation. Our adults usually have this tonic clonic state. Tonic can happen a lot, often in sleep, like this is saying, it affects both sides of the body, because remember, it's the whole brain, right? So we can have tonic-like seizures that involve one side, that would be one of your partial, but we're talking about full body. So of course, if they're standing and you go stiff, you eventually would fall, right? About 20 seconds. So you're seeing a little pattern here. You know, like trying to think of your studying, like how do you know? They're about like 1 to 3 minutes, but some of these individual pieces can be like 20 seconds at a time. All right. So same with the clonic. You got falling that can happen because of sudden loss of muscle tone, right? So it's going into spasming. So you're not coordinated, you're not able to hold yourself up. So you can see safety pieces showing up here. What are your priorities, right? Keeping somebody safe during one of these events. Okay, and some of the rhythmic limb movements, what I mean here, may not be symmetric, meaning they're not both happening exactly. It could be like uncoordinated type moving. All right. And so the myoclonic seizure. So myo, you know, is muscle. So this should be like a reminder that this is a particular muscle or muscle group. Again, this one's pretty quickly, occurs pretty quickly, typically with epileptic syndromes, usually in childhood. And this is a quick recovery. So anything that's got like 1 or 2 seconds is not typically going to have like a prolonged postictal state. And then we have atonic, which we used to call drop seizures or drop attacks. You might hear that word too. So atonic, absence of tone, right? If you break your words apart, you can figure it out. Fall from standing or slumping from a sitting position. Sudden onset, usually pretty quick recovery. So of course, risk for head trauma, right? Because it just comes on all of a sudden. And they're usually awake during that whole, you know, we talked about how loss of consciousness occurs in these generalized seizures, but it's because it just happens so quickly. They haven't had enough time to lose consciousness and track of time. But for that very brief moment, it is technically unconscious. I don't think I have a video. Nope, I don't have a video. There are videos of drop attack type seizures out there on YouTube. If you wanted to see some samples of some. I do have a video here for your absence. I was going to say pt1 for your absence seizures. She's I think a TikToker, has a lot of video of her seizures, and I think she's from the UK. I'll show you that in just a second. But this is a common one in children, right? Usually resolves by adolescence or late adolescence. And this is the staring one. So this is the one where the teachers would say, oh, they've been daydreaming in class all the time. They're just not paying attention, not responding. Could be absence type seizure. So that's staring and no understanding of what's going on. They don't respond. Hey, what's going on? And then all of a sudden they're back, right? Just kind of out of nowhere. So like I said, sudden start and a sudden stop. So you're just mid-sentence and then all of a sudden. And sometimes their eyes look around a little bit. And then they're back. It just takes a few seconds. It's like, pause, start, okay? You'll see a sample too. So it's not always caught because it can be pretty brief and it can go unnoticed, and it might look like the person's trying to think of what they're gonna say, right? I just had an absence seizure, right? Just like that. So I'll show you the video. But no memory of the event too. So she records them so she can see later, did I have seizures, right? And then she'll catch them. So teachers catch these a lot. When they've been teaching a while, they might see these.
Hello everybody, so welcome to my channel if you haven't been before. My name's Brogan. So today I'm going to be showing you some of my absence seizures that I had this morning. I've been needing to see her for ages. What's everyone doing today? I'm gonna probably go and see my sister. Like, I'm gonna have some absences. So, yeah. I'm gonna talk about my YouTube channel because when I talk, that triggers my seizures. So, what should I talk about? The new videos I'm going to be doing is like talking about driving and epilepsy. Driving and epilepsy. And obviously I've done the coronavirus one. And I know that this morning I am still in my pyjamas. I just woken up and I thought, can't remember what I was going to say. Thank you for watching, guys. So if you just want to subscribe, like and comment.
So she's an SNS documenting her journey. Brogan is her name.
That'd be great.
Okay, so that's typical or just your standard absence type seizure, sometimes called typical absence seizures. There's also atypical absence seizures, similar, but there's like some motor movement that goes along with it. So hers were typical, like you didn't see a lot of that motor movement, like lip smacking type things or blinking or twitching. But when you throw in those extra little mini, like fine motor type movements, like chewing, I used to see a lot of lip smacking in like babies, they just during that whole seizure, or the eye fluttering, or like hand rubbing motions during an absence. It's just kind of a repetitive motion. These last a little bit longer. Okay, so we got a little bit more than 10 seconds, up to even 30 seconds. And these type can continue on into adulthood. Okay. And that, just like your typical, it has an immediate recovery and no memory of the event. So then there's myoclonic absence. So if you understand each individual term and what's going on, you kind of put them together. We've got myoclonic type. So these get difficult because they look very similar. So we're looking at, is it generalized onset? It's just off of the absence type seizure when we throw in the motor component to it, right? So it's primarily the non-motor type with this other piece. So it could be that it's starting to spread and worsen, and so now we're going to start to develop potentially into future tonic-clonic type seizures with this particular type, right? So it was non-motor, and now it's starting to get a motor development, and then it could develop into a tonic-clonic type. So that's kind of what they're seeing with these. So that's why they're very similar, and you're starting to see like a little overlap going on, right? And then there's the eyelid myoclonic type seizures, so just specific to the eyelids, and those are pretty quickly. Sometimes the eyes roll back and you see the little eye fluttering. Anybody seen those? Right, so a little review. We got general onset. So general is coming from the whole brain, right? We got motor and non-motor, which types fall underneath. So basically your non-motor are those absence type seizures, the typical and atypical myoclonic. And then on the motor side, we've got tonic, clonic, tonic, individualized, clonic, and then tonic-clonic, right? And myoclonic without the absence piece, and the atonic, all right? We good? I know I'm going a little slower because I feel like you guys are like needing to process, right? Don't want to overstimulate. Throw you into a seizure. All right. So that's generalized. Now focal, I know I'm kind of working big to small here. So focal onset, seizure in a specific region of the cortex in one hemisphere of the brain. This type can develop eventually into your generalized type seizures. It starts in this focal point. You can have motor or non-motor here, right? You can have aware and unaware. And the symptoms are going to be based on where it's occurring in the brain. And this picture is kind of interesting. It's like, what do they call that? Phrenology or something like that, where they study the bumps. Now we actually know what kind of happens in the different lobes. So you've got your occipital, which is a visual disturbance, images of people or things that are not there. You've got your temporal, seizures in this area block speech, produce typical automatic movements, chewing, picking at clothes. So if they've got some kind of lesion or damage to a specific part of their brain, their seizure symptoms are going to have those type of movements with it. Because remember, this is excitation of those neurons, right? So visual disturbances, excitation, seeing things that aren't there. And then we've got frontal lobe area, disruptive behavior, running, screaming, fear, anger, impulsivity, right? Okay, so you get the idea. And I think this is an older graphic because it's talking about partial seizure, simple, complex, the old terms. Okay, so we have focal onset aware and focal onset unaware. Focal onset aware used to be simple partial. This is the most common type in adults with epilepsy. So an unprovoked seizure disorder, aka epilepsy, most common type. So remember, tonic-clonic was most common in your generalized type. This is the most common type in epilepsy, is these focal onset awareness. And people with epilepsy, like I said, may have this type of seizure, and they might have a tonic type seizure on another day, or if their meds aren't really controlled, they might go into full-blown tonic-clonic. And so they can experience different types of seizures. Again, it can initiate from one part and eventually spread to other parts to then become a generalized type seizure. You guys following? So that's why seizures can be confusing, because it depends on what's going on in the brain, which is why they all look so different. Because everybody's going to have a different type of injury and a different type of symptom. But in general, this one, they're aware of their surroundings during the event. Pretty brief, less than about 2 minutes, a couple minutes. Again, symptoms depend on the location of the brain. And then, so this can be considered that aura stage. So especially if it's like an occipital type onset. And then it progresses to it can progress to the focal impaired type. So remember, conscious and alert, focal impaired awareness, meaning their awareness is impaired, right? So patients have a loss of consciousness. Doesn't mean like their eyes close and they go to sleep, right? Eyes can be open, they just are not aware of what's going on. So our focal aware can develop into a focal impaired awareness. Again, these things can progress. So there are some motor symptoms, automatisms, that lip smacking, those fine motor things, that's what those automatisms are. Repetitive hand movements, eye fluttering. This is where, depending on where it is, if it's frontal lesions, they can have like this disruptive behavior, dangerous, embarrassing. Some have had seizures where they've removed their clothing. And so if you're out in public and you're just in the middle of the mall, it's really difficult. So imagine if the first time would be the time when they would learn that this is something that happens to them, or hopefully it's like something that happens at home and it's discovered so they know these things can occur. You know, so they have to have like a plan, or maybe somebody to go with them to help them, or start noticing some of their triggers. If they're having auras or a prodromal phase, they can kind of see some of these things coming and then get to a place where they can be safe and not do anything dangerous. So again, because of the loss of consciousness, there's no awareness of the event even afterwards. So they don't always know that they have one. On the focal aware, they do know they've had one. Okay, I think this might be my last video, but these are hard to understand, so I thought this particular video, It's a little bit longer, so I might skip through some of it. But I like it coming from the person themselves, because her seizure really, there's not a lot going on with it, but I like the way that she describes and explains everything. So she's also got a channel, if you want to watch more of her
you're
stuff.
new here. I'm Andrea. I have epilepsy. And if you're not, welcome back. Alright, so today's gonna be a quick one. We're just talking about focal aware, which used to be called simple partial seizures, and focal impaired awareness, which used to be called complex partial seizures. And why they changed the names and what the difference is, because I always was and still kind of am hella confused about what the difference is and why they changed the names. So yeah, let's jump into it real quick. So first up is the focal aware / simple partial, which is the kind I have currently. Hopefully that doesn't change. I used to have tonic-clonics, but we kind of got those under control, and now it is switched to this kind. Yay! All right, so the new name is focal aware, I guess more medically accurate or descriptive. I think they did a huge overhaul of name changes of seizures back in 2017 that my brand research has shown. So these occur on one side of the brain. There is no loss of awareness. You are fully awake through the whole thing. You may be frozen, so you may not have movement, be able to speak, but you are aware of what is going on the entire time. So like if you see somebody standing over here and then they walk to the other side of the room, you may not be able to like watch that happen, but when you come out of it, you know that they have moved over there, you were aware if they were talking the entire time. On the other kind of seizures we'll get into in a second, you may have started out seeing them there, but when you come out of it, you're like, how the hell did they get over there? When did that happen? Why did that happen? Da, 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 da. So, alright, and so just real quick, I'm going to show you a video of what my personal, yours may look different, focal aware seizure will look like, where you can tell that I'm aware here, but still a little bit.
Can you see that lighter now? You see the light?
Alright, so here I am alert. He just asked me if I can see the light, but I'm confused because I don't know if he's talking about the light from the camera or the flashing light that's happening in my right eye from where my seizure is located in my brain. So I'm very aware that he is there recording me, which I've asked him to do, but I'm just annoyed as I'm focusing so hard on trying to get this light to stop happening, which I can't do because my seizure's got to run its course. But yeah, I'm very aware that he is there, that my son's taking a bath in the other room, that everything is going on around me. So this is what a focal aware seizure looks like for me.
These focal aware seizures are usually brief, usually less than 2 minutes for the actual in-depth seizure part of it, not the leading up to it, not the other part of it, but yeah, it's usually pretty brief. And obviously, depending on where in your brain it originates, comes with the involuntary movement, either lip smacking, or mine is in my occipital lobe, so my involuntary eye movements, or hand rubbings, all that kind of stuff can come along with this kind of seizure. So yeah, used to be called simple partial, now it is focal awareness.
I'm gonna stop it right there because she doesn't show the other type, because the other type would look the same way, except she's unaware. So you can watch her full video, or you can go to her channel, and she's got some older tonic-clonic ones when she used to have tonic-clonic type. They adjusted her medications, and now they have better control. But interesting, it's kind of neat how the internet works now. There's a lot of people posting their experience, and others see, and then they realize, oh, that's my daughter, or that's my aunt, and they say, hey, maybe you should call your doctor and talk about, maybe getting that checked out. So, all right, so focal onset, let's make sure I didn't skip, okay. So we talked about awareness, oh no, sorry, okay. Focal onset, aware, and impaired awareness. And she mentioned a little bit about motor activities. Again, so this all starts with where it is in the brain, which makes it in this category as a focal type seizure. So you can have focal ones with awareness and inawareness, and motor and non-motor, right? atonicity, tonic, clonic type. There can be some muscle spasms in there, right? So it can be the myoclonic or the larger clonic. Strange behaviors, repetitive, purposeless, the automatisms that we mentioned, okay? And then on the non-motor side, this is where some of those emotional pieces come in. So it depends on where that focus of the origination of that misfiring is occurring. Okay, let's take a break. We do 5 minutes so we can get through some of this maybe? Or you need longer, 10 minutes? 10 minute break, all right. 2:19.